My name is Waikit. I'm from Singapore, but I'm actually from Ipoh. I always say that you can take Ipoh out of, you can take me out of Ipoh, but you can't take Ipoh out of me. I work in Singapore National Hospital, NUH, and the National Institute of Hospital Singapore, and I'm here to share our experience with this system. Can I? Okay, good. Okay, great. Now, Dr. Hans has done the difficult part, the science part of the whole the system, and why chyme recycling is such a wonderful thing. Okay, in my short, I would say in my short, humble surgical career, I've come across enough surgical devices. I've come across surgical devices. Okay, they don't pay me. I'm actually here for the holiday in Penang. I'm going to leave here very soon. So, but I'm here because our patients and ourselves as surgeons, us ourselves headache, heartaches, wondering what to do with the patient, and the patients themselves suffering in front of us, and how this system has actually done so much for our patients. I'm here to share with you because I seriously think that this is one of the devices in my career, in my short career. In a way, I say that, wow, this is really something. Okay, I'm a colorectal surgeon. I do sarcoma surgery, and I do peritoneal surgery too. Now, Dr. Hans is upper GI. This is a colorectal meeting. I'm a lower GI guy. I'm telling you, this is a tough war. So take back the small bowel from the upper GI guys. Yes. That's why our unit is actually called Division Upper GI, and sometimes small bowel surgery too. Okay, then when I first laid my hands or first seen this system, I said, why didn't I think of this? It's such a wonderful thing. My explanation of this thing is almost like those of you who rear fish. You know, your aquarium, where they pump the water and go up and come down, and no smell, perfect. This is a system. It is so simple yet so powerful. And I'm here to share my experience, okay? Now, this is a condition whereby when you need this system, it is not something that you look out for these patients. There will never be a randomized control trial, number one, because no one patient coming to you with small bowel problem will have the same characteristics, and you cannot randomize them. Now, I've used this since 2002, and my case series is not big because I'm not hoping for a big case series, but I'm here just to share my experience with you all. And this is a scenario, but my N is equal to 1 for each of the scenarios, okay? Now, Dr. Han has really done this. He said, this system, I said, simple works and complex fails, because it's like actually KISS. It's simple, stupid, right? Exactly what the innovators have done, because it's so good. Those experience that Dr. Han mentioned earlier about how we collect the chyme, put back inside and things like that, we doctors usually leave it to the nurses to do. Chyme is really, really foul-smelling. Have you actually smelled it? It's really, really foul-smelling. But chyme is gold. Chyme is gold. Because GI tract, as you understand, the GI tract is the biggest, most bacteria are all there. It is so important. The GI tract is so important. It is really foul-smelling, but it's gold. It's no easy work to collect, to process, and to reintroduce it back to the system. Yesteryears, done in an open system. You have seen the pictures. And our poor ladies, okay, the patient will suffer because it's very smelly, it's cumbersome. The nurses, the caregivers, actually can put them off and say, enough of this, until I've seen this system. Now, I don't have to emphasize what chyme recycling can do to the patient. Dr. Han has actually shown that just now, right? The best route is actually to be able to eat. Patient can enjoy the food, can enjoy drinking. That is very important. We eat not to survive. We actually eat so that we can shit. Right? So sorry, your lunch is coming soon. Because enjoying eating is a big thing. You keep patient new by mouth, cannot eat, cannot drink, and then on TP or on parenteral nutrition, it's actually not a joy, seriously. Right? To be able to eat and taste is actually wonderful. And this system allows us to actually Patient can eat, just recycle it back inside there, that's all. Now, the rest of the things like dehydration, electrolyte imbalance, all these are just the rest of the things. Patients getting hepatic dysfunction, patients getting line sepsis, keep on changing their lines. It's not an easy thing, it's no joke. Now, I think compliment should be given when it's due, and it's due to this person, okay? Why didn't I think like him? Okay, then I'll be a rich man now. But we shouldn't make this system to make money. This system is made to save people. Professor Ian Bissett, I didn't meet him when he came to Singapore. I think my colleague actually had conversation with him, right? Yeah, Daryl did. Yeah, he made he's a genius. He made complex ideas very simple. And afterwards, if you have a chance, look at the system. It is wonderful. Okay. Now, this man, if you can just take that link, he's actually served Nepal for many years during his earlier years. Now, the story goes is that I would love to see him one day and then talk to him and listen to his stories about his time in Nepal. Now, he treated a 29-year-old lady, a mother, and who had bad infection. I mean, the rest we know lah. Bad infection, operate on this patient, poor nutrition, sepsis, and things like that. Anastomosis didn't heal, leak, fistulas, everything like that. Eventually, this lady died. Okay, she battled for 3 months, and she eventually died. Now, but that is important for him, and he went back to New Zealand, and he came up with this thing. Okay, now, I'm going to tell you our journey in Singapore in our institution. First attempt, it was a failed attempt, and always surgeons, we're all surgeons, right? You're all colorectal surgeons except one upper GI surgeon. Okay, we always said, that's not my patient. I was consulted, I'm coming here to help out. Okay, again, okay, it was June 2002. Now, this poor lady, as usual, the usual kind of background. Old, elderly, end-stage renal failure, the usual thing on dialysis, hypertension, diabetes, cholesterol, stroke, AF, on anticoagulation, the whole works. Usually they give you the full thing. Now, she presented in June 2002 with purine peritonitis due to ischemic gut. Okay, on inotropes, many surgeries. Let's say had 3 relooks. The 4th one, a bit of conversation with us. We sit down over a coffee one day, we're discussing it. Now, if you look at the picture, the one on on your left. Now, this is how the configuration of the small bowel looks like. 50 centimeter from the DJ flexure, the jejunum, 15 centimeter dangling in the middle, and 170 cm from the IJV, from the ileocecal valve. Actually, quite good, you know. I like ileum. I mean, those of us, I'm sure Dr. Han said that, yes, a lot of things happen in the jejunum, but no jejunum got ileum, still got chance, right? So this one has got 170 cm of jejunum. So somehow or other, we always say the other team, so keep on doing relooks, okay? Every 2 days, first relook, second relook, third relook, and fourth relook. Then they said, oh, about time now. Mind you, on the 4th operation, which is a third relook, which is almost about 6 days after surgery. Those of us who have done enough of these bad cases, you know that by now, bowel edemators, cocoon together, abdominal wall retracted, bad time. Decision-making time. Friend consulted, said, hey, what would you do? I said, my gosh, let's build out, right? Let's build out, just put out stoma. The time I didn't know about this system. I said, let's build up, put out a thing, and then fight this battle first, okay? Then we can do our recycling, do the hard way, whatever kind of thing. Then we started searching, and then we heard about a friend came back from a year in UK and said, hey, there's a system called Insight System, but it's not in Singapore. You know how difficult to get a system to Singapore? It takes months to get a system to Singapore, I'm sure, right? You know. So then we said, never mind, let's do what we have to do to save the patient first. I said, pull out. But conventional wisdom, everybody will say, let's join it up, right? Because I always say sometimes we think like ostrich. You put the head into the sand, everything outside is okay, don't see them. So you know the rest is history. We join it up, close the abdomen, then the patient leak the next day, right? It's the usual sequence. Leak the next day, they did a 5th op, Then we do use all the magic in the world, suture, repair, tissue, glue here, glue there, and everything like that. All due respect to all the products and things like that, but this is life, right? Leak again, some more leak, six operation. 2 days later, went again, still leaking. Finally, the decision now said, I think it's about time to pull it out. By this time, the bowel is all, the mesentery all shrunken, shortened, edematous, cannot bring it out. Principles of surgery now is to bring it out, right? But you cannot bring it out. Tried very hard, cannot bring it out. So we tried, cannot bring out through the usual route in the left upper quadrant. So we bring out from into the mid, but just above the fascia. Better than nothing, okay? Now, then partial wound closure rate and the other rescue called the negative pressure wound therapy. I'm here for you, but that's another system I said has changed my life in surgery, okay? This negative pressure wound therapy, we can do magic with it, right? You can do all sorts of modification, and then we slowly cooks the thing. Eventually, 3 other operations, we leak and things like that. A few more holes happen in the proximal stump. Finally, the stoma can be seen outside there. But by now, inside system came with parenteral nutrition. We have difficulty inserting the tube into the efferent loop. Why? Because probably quite convoluted the way it came up from the midline wound and things like that. Okay, we couldn't do it. Patient on parenteral nutrition. Finally, almost 10 months later, we close, reverse, and then the rest is history. This lady had, by that time, about 10 centimeters from the DJ flexure, efferent loop of 150 centimeters. We join it up with 160 centimeters. You have ileocecal valve, you've got an entire large bowel. Patient is okay. She's actually okay now. This system seeded the thing in me that this inside system is something seriously we must consider it, because eventually we will have many other patients that'll be like this. Not the best case. To me, it's a good case. It's a good first case. Let me think about this thing. Okay, then become braver. But I learned from this is that hesitation only enlarges and magnifies the fear. But I change the fear to the whole. Hesitation only enlarges and magnifies the whole. You must take action promptly and be decisive. Take action promptly and decisive. That's what my advice is. My learning case from this. My second case, I think something in between. Okay, I've got a September 2023. I'll put it our real first all the way and successful patient. This is my patient. He was in his early 50s, a lecturer in NUS, educated man, motivated wife. Unfortunately, he suffered from low rectal cancer. After radiotherapy, we operated on him, reversed his ileostomy. Unfortunately, about 2 years later, he developed a metachronous lung cancer. Treated that, but shortly after that, okay, he had a lung surgery, and from about 2 weeks, 3 weeks later, he developed a acute abdomen. He's so unlucky. Now, he developed an acute abdomen, prurient peritonitis. He has a closed loop small bowel obstruction with ischemia. He reacted quite badly to his sepsis. He was on high dose inotropes. Temporary close, that's the usual thing, resected it. So what we have now is 165 centimeter from the DGF fracture, 35 cm from the IC valve. About 2 days later, almost about less than 48 hours, we said it's about time to go in. From my first experience, I said, now, this young guy, fit, let's go all the way and don't go this relook. I decided to pull out the stoma straight away. Though you can say 165 is actually adequate, but my first case, going all the way, still on inotrope, I pull it out, a double barrel, and then I close his abdomen straight away, okay? This is my experience. I dare not mature the stoma because he still had ischemia. Now, again, this was my second case in a way. So I could see how a stoma outside looks like over the next 1-2 weeks. Fibrin edematous, fibrin covering it. It looks so ugly kind of thing. But eventually, I matured the stoma, and the patient was put on a week later after the surgery. I actually put him on the inside system, off the TPN. Everything is corrected from then on. And this man actually survived for another 15 months. and then I reversed his stoma. All this while, he could eat like usual, okay? Yes, we have dietitian telling us that cannot eat this, cannot eat that, and things like that. I tell patients, just chew your food properly, okay? Look, cut down a bit of fiber, eat what you want to eat. You won't have that much appetite anyway. Enjoy your food. That's my advice. But I know background, my dietitian, my stoma nurses will be doing something else lah. When the pump gets blocked or whatever kind of thing, that part they don't tell me. So, unfortunately, this man, during this period of 15 months, he developed brain mets and needed gamma knife therapy, craniotomy, more chemotherapy, and finally, he had enough already. In April 2024, he actually developed multifocal disease, lung mets, peritoneal mets, lymphatic mets, and things like that. So he said, can you reverse it? And then after, with the chemotherapy, the disease was stable. I went into a cytoreductive surgery, reversed his stoma. He was happy, okay? He was happy and decided to go home. He's from Canada. And then he developed some more brain mets and eventually died. Okay, but he died without stoma, kept his nutrition intact. And this man, I didn't have to do anything because I just want to emphasize how simple this system is. The wife is the one who's changing the tube. The wife is doing everything. I don't have to do anything. She just come and show me the pictures and things like that, send me a WhatsApp picture and things like that, and nutrition all maintained. I would say this is my very good, successful second case. Creating a stoma for the right reason is not a failure. You know, colorectal surgeons, our job sometimes is that creating a stoma is like a failure. It's like almost we're going to jump off the high-rise building kind of thing. But think about it, okay? Now, the next few cases I'm going to run through is just proximal jejunostomy. Some of them is high jejunum stoma together coupled with a colon, some jejunal ileal, but this gives us more confidence in doing these cases. Now, this lady, again, the whole works, she has end-stage renal failure, she had RCC, lung mets, and somehow or other she developed a closed loop obstruction from a surgery, ischemia, and then extended right hemicolectomy, that means extended to the small bowel, leaving about 110 centimeters of jejunum, and she has a mid-transverse colon present, and then we pull it out straight away, and then we recycle her. She's actually a very motivated lady. She said sometimes when the output is not much, she doesn't recycle. She just eat like usual. When it's out, then she'll recycle. She's actually she can do all these things for herself. Second case, a patient with unfortunate diverticulosis of the small bowel and large bowel, very extensive, previous hemorrhage, whole host of medical problems, and somehow or other, the small bowel diverticulae perforated, infected and perforated on two sides in the small bowel, about 140 centimeters from the DJ flexure. We resected it, and then we pulled out the second surgery. We really decided enough. So after the first few experiences, they'll consult us, and then we said, we just tell them that just pull out. Do a good, nice double-barrel jejunal ileostomy, and then and the patient continue the chyme recycling. Unfortunately, about 2 months later, another perforation happened. We resected. Now she has got a proximal stump of 75 cm from a DJ fracture, and a colon, no ileocecal valve, no right colon. He has left colon, and this man is actually doing quite well with our recycling. Okay, I don't have the slides to show you how his weight, height, nutrition, everything, but believe me that they're doing okay. Next patient, another poor man, sigmoid colon, closed loop obstruction, had an open subtotal colectomy, ileocolic anastomosis. Unfortunately, has a large midline incisional hernia. The liver mets was treated, and then surgery was done. That was almost about 2 years after his index surgery. Now, after his hepatectomy, he developed about a week later, he developed rising lactate. The hepatobiliary surgeons brought him in, dense adhesion, somehow or other. He reacted very badly, developed lots of adhesions, found nothing, everything good, closed temporarily, and then finally closed it 1 or 2 days later. About a month later or 5 weeks later, then they said that no, this man now has intestinal obstruction, and then we can't do anything about it. And then we have to bite the bullet, go in, and resected lots of bowels because he's got multiple loops of small mid and distal small bowel. The ileocolic anastomosis previously were all stuck together. At the end of resection, he had 60 cm of jejunum to the DJ flexure, 120 cm of intervening ileum, and the recto-sigmoid colon stump. On anotropes, quite okay, and then we temporarily close it first because I want to let it rest for a while first, not too long, go in again, and the next day we went in again. This time I decided that enough is enough. I brought up the two small bowel loops out in a double barrel jejunostomy. I joined up the ileocolic anastomosis because use the proximal one to protect the distal one. I know we don't like to use the word protect, it doesn't protect, okay? It's just divert it first, and then we waited for a while for ensure that the anastomosis is good, and then we started recycling him. This man now, I've seen him for past, he came in March to see me. The wife is doing for him. He's quite a lazy guy. He's like a big boss sitting on the wheelchair, sitting on a chair there, he doesn't want to touch it. The wife said, I'm the one doing it. At night, daytime, the wife is so good. But I'm not ready to close him yet, but I'm going to close him eventually. You look at the picture, the two stoma is so prolapsed. But I decided not to do anything about it. I continue to put in the inside tube. The inside tube is actually quite good. There's a part they can adjust on how much the length to go into the small bowel. Have a look at the system. I keep adjusting it, and it's not coming out. I just let it be because I'm not ready. I'm not going to shorten the small bowel anymore. Okay, another case, almost the same scenario, and then this man got 175. Okay, the thing about him is that he has got small SMA thrombosis, a chronic SMA thrombosis. They went in, they resected it, and after 1 and 2 surgery, the third surgery still has got the ischemic segment, re-resected some more, got 175 cm now, but 100 cm of it is very congested. We said, now, about time, and patient has got lots of medical problem and not very sick. We decided just to close him and see what happens. He actually survived, and he has got a double barrel ileocolostomy, and we actually be feeding him. Now, those are the cases that we gain more experience. Then we challenge the system by having a stoma. This is a case whereby we only can create the stoma in the midline because we cannot pull it and pull it out from any in a preferred location anymore. We did this because this patient, he put it into the midline. So the picture to this case is that the stoma is actually at the lower end, at the lower end, the inferior aspect of the wound there. That's the only place we can put the stoma. And then once things controlled with the negative pressure wound dressing, and actually the patient is still on the therapy from us. Then there was another patient that actually has got a poor history of bad incisional hernia, bad story. I'll tell you in a short while, whereby at the end of everything has got an open abdomen. We have no choice. We just created the stoma in the open abdomen, and we continue to use wet dressing, and then refeed the patient through there. For a 9-year-old man from Nepal, luckily he's from Nepal because he has gone back to Nepal, and because Professor Bisset is from Nepal, was in Nepal, he actually trained some people to use his system. Went back in April, May. I haven't heard from the wife. I'm sure. Oh, sorry, April, May last year. He actually heard from the wife yet. He's actually doing quite well. Have you heard of Nepalese going for liposuction? This guy went for liposuction. He went for liposuction in May 2024. Apparently, he's a model for some product in Nepal. So about a week later, feculent peritonitis, we all know the story because the liposuction also liposucked the small bowel. So multiple enterotomies, and then waited for a while, necrotic anterior abdominal wall, 4 surgeries done there. Because it's all cocoon, they have no choice. They join the bowel. As usual, you know, it leaked. And eventually, at the end of the day, from the story, from the medical reports, he said that more than 100 centimeters of DJ flexure, from the DJ flexure, and unable to bring out the efferent loop, so it's an end jejunostomy. He came to us we waited, we said, since your nutrition must be enough length, because he's maintaining his nutrition, and then he came to us almost about a year later, and then, so brave of us, we went in to reverse his stoma, unravel all his adhesions, close the hernia defect, the incisional hernia defect, big one, with component separation. Before that, has got Botox injection. Did well for a while, because it was done on the 3rd of October. About a week later, unfortunately, he started to leak. Okay, we went in, he leaked about 85 cm from the DJ fracture. Okay, I took a chance. Okay, I know, I said it earlier, I stupidly took a chance. Okay, then we surgeons always say that because there were so many other surgeons who say that it's okay, it's a small hole, close it up, it's okay. So I took a chance, I closed it up, I expanded all the meshes, and unfortunately it leaked again about a week later. So this time we had no choice already. So I exteriorized both the stump, but we still cannot close the incisional hernia. The muscles couldn't come together. So we exteriorized it, and using modified the wet dressing therapy, we managed to bring everything together. Eventually it looks like this, and then later it looks like this. I'm sure it looks much better now, and we're recycling him. Knowledge is of no value unless we put it into practice. Now this system, this chyme recycling, actually is, you need a lot of thinking and see how you can improve and use this device. I tried, because I do colorectal surgery, I do low anterior resection, I see patients coming in Last syndrome and things like that. So one day I got a very motivated patient from New Zealand. He's a Singaporean but stay in New Zealand. He came for surgery, everything. Then, since he got a bit of money and he's from New Zealand, I said, hey, I heard of this device, you want to try or not? Before I reverse your ileostomy, I want to recycle it for purpose of, you see, when we close the stoma, after a few months, the patient got the better with diversion colitis and diversion colitis, okay? The patient got the better with the Last syndrome, right? So I said, it's a crazy hypothesis. Let's try. I recycle you first now. I treat your diversion colitis, so let's try to reverse it as much as possible, so that by the time I reverse you, so that you now only tackle the Last syndrome in that sense. And it's also you have a feeling of how your Last syndrome is going to be and recycle. We tried for 2 months for him. He said, well, okay. He said, I'm okay with it, but I also don't know how much he recycled. Now, this is my n equals to 1 scenario. Okay, my advice is that if you want to try, can try. I actually almost have another patient to try, but I decided not to. So I tried for this patient. Now, try and fail, but don't fail to try. That's all I can say. Now, then I started pushing the indications. 3 more cases. Double stoma. So sometimes the cases, you get to do what you have to do. That's all, right? This patient has got a small bowel lymphoma of the small bowel, operated in the private hospitals. Don't know where. We don't have any history. All we know that he has got transverse colostomy, and he has got. Okay, sorry again. He had sigmoid colectomy earlier for volvulus. Okay, and with a dysfunction colostomy, and he reversed the colostomy. Then he had an obstruction from small bowel lymphoma. By the time he came to us, he has got by the time the first surgery there's a transverse colostomy and resected the stenotic small bowel from the lymphoma. He leaked, and then brought a double ileostomy. They said 250 cm from the DJ fracture, but the output seems to be very high. We don't know why. And then now the patient has got a double barrel ileoileostomy, and then he has got a colostomy. Now, somehow or other, the output is always high, keep coming to the ward with dehydration and electrolyte imbalance. But mind you that he's still getting his systemic therapy and also had stem cell therapy. So now we're recycling the ileostomy site, and he poo-poo from the colostomy site. Though the colostomy, we don't have the measurement of this, but somehow or other, the colostomy site is actually quite firm, and actually the patient is doing quite okay. And this patient is still being treated in the ward. I'm still waiting for all these things to settle. Hopefully find a time. Hopefully we can reverse him. This is another unfortunate lady. She has got one of my patients with a large intraperitoneal liposarcoma. And during the excision, we needed to do a small bowel resection and ileocystectomy. So all in all, she has got 145 cm of small bowel, 2 anastomosis, small bowel, and then ileocolostomy. Unfortunately, about a month later, about 7 months later, he came in with a perforated ileocolic anastomosis. I'm not sure why. We're actually struggling and find out what's the reason for this perforation. So eventually, from the diagram, let me see. What happens is that everything is caught inside there, and we have to resect. And the patient now has got almost about 120 centimeter of DJ flexure, from the DJ flexure, intervening 80 cm in the middle, and only got rectosigmoid colon, that's all. Because everything is caught inside there. Temporary close, sorry. Okay, temporary close, created 2 stoma eventually, a double barrel ileoileostomy on one side, on the right side, and a double barrel ileocolostomy on the other side. This one I'm still fighting because she's very thin. We actually have to give her enteral, recycling, and parenteral nutrition. And something we are trying to help this lady with that because she just can't, she keep coming in with dehydration, electrolyte imbalance, and sepsis. And this is one of the cases that we are still struggling with. Now, this is a double stoma, and then that's what happened to her. Like I said again, sometimes you got to do what you have to do. You get a motivated patient, motivated families, and then got a good team, then we can get this thing going. This is my latest adventure. It's about 2 weeks ago. I had a patient with a malignant obstruction. 66-year-old, very motivated, he's still on systemic therapy. Unfortunately, he had a locally advanced urothelial tumor of the mid-ureter right side, involving the right iliac vessels and psoas muscle. The urologist deemed irresectable. Treated with radiotherapy there, local therapy there, and then palliative systemic therapy. This all happened in last year, December. Now, this time, he presented to us with recurrent subacute obstruction. And then discussion with the urologist and the medical oncologist is that he still has a chance, but I say that he's actually quite blocked. He has got a malignant obstruction. 2 portions. He has got a distal small bowel stuck down there into the tumor, and then the sigmoid colon pulled to the tumor and stuck down there. So eventually, with the discussion with the family and everything, he said, if you have no food, cannot eat orally, no systemic therapy, unless they say they want to give TPN and start giving and continue the systemic therapy. But decided to go in. We did a double barrel ileocolostomy, and then descending colostomy. Now this is how it looks like at the beginning. That 240 cm of small bowel, I thought after irradiation it might be giving problems, but still he's doing quite well with it. Now, what I'm trying to say is that sometimes is that with this system and you're faced with a tough problems, you have to think out of the box and see how you help them and discuss with them. Now, what Professor Bissett said this in the website is that not encourage your colleagues. Ourselves sometimes is that if you think that in an emergency, if you join, sometimes you'll end up in trouble. Just bring out both sides because we have a system now, and this insight system is actually life-saving. Where a new invention promises to be useful, it ought to be tried. This is my advice. Okay, I am actually, this sounds a bit cheesy, doing selling koyok for them, but I'm actually now I'm more brave and confident to deal with small intestines now. He said I took up colorectal surgery. Why? Because I thought dealing with the colon rectum is actually very challenging. I was wrong. I think I must tell my teachers last time my teachers, not here, they're all quite old already. They said when I was a junior, you saw the small bowel, it's okay, you can, because small bowel is the most, you leak the least and give least problem. I want to tell you today is that the small bowel is the one that is most difficult to handle. And now with the insight system, cheesy statement again, is that it actually made life easier for us. With this, I thank you for the journey and experience.
Thank you so much, Prof.